So our next presenter, Charles Rosen, is with us today from the Mayo Clinic, Rochester, Minnesota, and he will be discussing the role of liver transplantation in the clinical management of EHE. And as someone personally who has undergone liver transplant, I just want to send a personal thank you to you, Dr. Rosen, for your dedication and expertise in this space. So please welcome Dr. Rosen.
Thank you, Jenny. It's indeed a pleasure to be here, and I greatly appreciate the invitation to do so. I too have a personal connection to this disease. We had a close family friend that acquired this disease, and when I first came back to Mayo Clinic in the late 1990s, contacted me about a liver transplant, but unfortunately his disease progressed too quickly and he succumbed. And so I too have been able to observe the devastation and the suffering, not only from him, but from his immediate family and for all of us that knew him. I do not have any disclosures. And what I would like to do in the next 15 minutes or so is talk a little bit about liver transplantation for EHE. But first, I'd like to mention a few things about transplantation for malignancies in general, and then to discuss the role of transplantation versus that of resection for EHE. We'll review the results with transplantation, talk a little bit about patient selection, propose a treatment algorithm, and then finally, I'd like to mention a few things about donor organ allocation as well. In liver transplantation, like in anything that we do in medicine, we really have two aims. We're trying to not really treat a tumor or treat a disease, but we're treating patients. And in treating patients, we're trying to help them live for as long as they possibly can and to live the best quality of life that they can. And for me, that means basically we're trying to add years to their lives and add life to their years. And keeping that in mind, however, in transplantation, as in any aspect of medicine, one of our values is that the needs of the patients come first. Indeed, this is the primary value of the Mayo Clinic. But there are some confounding issues when we talk about transplantation for malignancy. We have to exercise appropriate stewardship because we do not have enough organs for everybody that needs them, and we have to make the best possible use of those organs. We have to consider donor organ availability when we're offering transplantation to our patients. Transplantation is very transparent, and we always have to be aware of our performance metrics that are viewed nationally and by payers and by the public at large, in addition to patient outcome. Stewardship. Basically, when we're deciding whether or not to go ahead with a transplant, the basic rule is whether or not we have a reasonable chance for success. From a survival standpoint in the transplant community, that's generally about 50% 5-year survival. But what is the survival benefit? How many patients are we helping? And I'll say a little bit more about that later. And should that be driving our decisions? And I think it should. We also have responsibilities because we do not have enough organs for everybody that needs them. We have a responsibility to make the best possible use of those organs for the deceased donor families that have been generous in their donation. We have a responsibility to other patients that are on our waiting list that are essentially competing for those organs. Unlike a resection or an operation, we can't just schedule a case in the operating room. And unlike other physicians, we can't just order drugs or treatment modalities or schedule those, but we have to wait before our donor organ becomes available, and our other patients are competing with them. And then finally, with living donors, people that are generous enough to put their life at risk to help save a loved one, a family member, a friend, or perhaps even someone they don't know. For a living donor, should we accept more or less of a chance for success? I personally believe it's about the same, but that's debated oftentimes in the transplant community. As far as donor organ availability, there's a waiting list, and there's a national prioritization in the US and in Europe for people awaiting liver transplantation. We have to consider that along with the organ availability, which differs from location to location, not only within the US, but within Europe and the rest of the world as well. And as I mentioned, transplantation is very transparent, and all of our results for all of the programs in the United States are published for the public to review. In addition to that, UNOS, the United Network for Organ Sharing, which is the organization in the United States that oversees organ donation and allocation, credentials programs based on their results. as does Medicare and all of our third-party payer contracts. Um, all commercial insurance plans will look at the transplant center's results before they'll agree to have their patients transplanted to those centers. In addition to that, there's the public perception because our results are so readily available for everyone to see. Then, of course, with patient outcome, we not only have to worry about the response to the disease, but there may be underlying liver disease as well. We have to consider the progression of disease while patients are awaiting transplantation, and patient suitability for transplantation, which includes assessment of comorbidities, their compliance, their age, and underlying health. And then keep in mind also that because EHE is such a rare disease, the series span a great deal of time, and transplant results have improved tremendously over time. When I first started my fellowship in 1989, for instance, 1 year survival was in the mid 80 percentile. Nowadays, it's in the mid 90 percentile. So that's just at 1 year. So there's been tremendous advantages over transplantation that we have to take into account when we're going through the literature. As you know, and as Dr. Kuno mentioned earlier, EHE has multiple growth patterns. More often than not, the disease presents in a nodular fashion, and otherwise it'll present with a diffuse growth pattern, about 60 to 40%. These ratios vary depending on the series. We also have to be very careful to discern the difference between angiosarcoma and EHE, because EHE is a rather indolent disease, but if we inadvertently transplant somebody for an angiosarcoma, they're destined to have a rapid recurrence and not survive very long afterwards. And many of us have made that mistake. As far as the treatment for EHE, in a published series from Cancer in 2006, transplantation was about 45% of the cases, observation in 25%, chemotherapy in 21%, and liver resection was only 9%. And this shows a resected specimen with a nodular growth pattern and several nodules. And the series for resections, there really aren't very many, and they're quite small. I tried to pick one that was more recent. This was from Asan Medical Center in Seoul, Korea. I happen to know the surgeons and that program very well. And they only treated 6 patients between 2010 and 2014. Their 1 year disease-free survival and 3 year disease-free survivals were 83 and 44%. But most importantly, all of their patients were alive 9 to 65 months after resection with a mean follow-up of 43 months. So resection appears to be a viable treatment option, even though it doesn't seem to be done that often. Back in the early 2000s, we did take a look at 30 patients that were treated at Mayo Clinic between 1984 and 2007. That included 21 patients from Rochester, 5 from our sites in Florida, and 4 from our site in Arizona. And then we compared our results with resection versus transplantation and also with non-operative therapy and with the 42-month median follow-up. And Scott had shown a little bit of these results earlier. But most of these patients, almost 70%, presented with pain. A third of them had metastases. Almost a third of them were asymptomatic, and 2 presented with liver failure. The treatment involved resection in 11 patients, transplantation in 11 patients, and non-operative therapy in 8. What we found was that overall patient survival with resection was fairly comparable to that with transplantation. As you can see, the p-value doesn't show a significant difference. It is hard to assess what these results mean, however, because keep in mind that the patients that underwent transplantation had a waiting time. So this curve should actually be shifted to the right a little bit, and because our intent to transplant patients resulted in a waiting time, and the decision to treat someone with transplantation, you make a decision and place them on the waiting list, they accrue time and then undergo transplantation. Whereas with resection, we can decide to go ahead with a resection and do so perhaps even the next day. And so when we look at intent to treat analysis, it's different than using time zero as transplantation. And unfortunately, you can see that those patients that were not suitable for surgical therapy, shown in yellow, did not do as well. When we look at several of the risk factors or prognostic factors, we found that those patients with more than 10 lesions, as shown in yellow, has significantly decreased survival compared to those that had 10 or fewer lesions. Likewise, tumor size, those patients that had a single lesion that exceeded 10 centimeters in diameter fared much worse than those patients that did not. Excuse me. And those patients that had a diffuse pattern of growth fared worse than those patients that had a nodular pattern of growth, and that probably even accounts for some of the difference or that we see between transplantation and resection, because all of those with diffuse disease pretty much underwent transplantation. When we look at liver segment involvement, patients that had more than 4 segments of the liver, there are 8 segments of the liver. When more than 4 or half of those were involved, they fared significantly worse than those with less than 4. And for that reason, uh, excuse me for flipping back and forth, we looked at the different prognostic variables, and as you can see, the 5-year survivals here, those patients with 10 tumor nodules, tumor size greater than 10 centimeters, or diffuse growth pattern, or involvement of more than 4 liver segments, had significantly worse survival than those that did not. This includes both the transplanted and the resected patients. Interestingly, about 30% of our patients had extrahepatic metastases, which did not seem to affect survival. And 9 patients, 4 after resection and 5 after transplantation, underwent subsequent interventions for recurrent disease. So we developed a 10-10-4 guideline that patients with more than 10 nodules, a mass greater than 10 centimeters, and or diffuse disease with involvement of more than 4 liver segments have a poor prognosis with resection and are best treated with transplantation. But in general, we favor resection when it is possible to do that. Showing an algorithm here. This shows those patients with nodular disease, less than or 10 nodules, less than 10 centimeters for the largest lesion, and less than 4 segments being involved. We generally prefer proceeding with resection or even ablation, and can even treat local recurrence the same way. The patients with diffuse disease, more than 10 nodules, larger lesions, and greater than 4 segments, we proceed with liver transplantation. And for those that have extrahepatic involvement, we still can proceed with resection, but consider chemotherapy and removal of metastatic disease, and then show a dotted line to liver transplantation, which I'll make a few comments later when we look at several of the other series about transplantation in the face of extrahepatic disease. So as far as liver transplantation for EHE, there's really 2 large series, one from the United States, which is a UNOS registry study published in this past year, and another from the European registry published in Transplantation in 2017. There are several other studies worth mentioning, a Canadian study of 11 patients in 8 centers showing 82% 5-year survival, and a study from Pittsburgh dating way back to 1976, before we even had cyclosporin or tacrolimus for immunosuppression, showing 172-month mean survival. They actually found that arterial chemoembolization was better than surgery for patients that had extrahepatic metastases at the time of presentation. As far as the United States series, the UNOS database includes 131 patients that were placed on the waiting list between 2002 and 2018. 92% of these patients had a MELD exception score, which I'll mention in a few minutes. And 43% or 43 or about a third of these patients didn't receive a liver. Either they were removed because they did not survive till transplant, or they became too sick. Several no longer needed one. I don't know quite what that means. 5% were still waiting for a transplant, and 10% was unspecified reasons. This is the way the data are coded when patients are taken off the waiting list in the United States. 88 of the 131 patients, or almost 70%, underwent transplantation. Most were with deceased donors, but 5 were done with living donors. These were done at 50 different centers across the United States, the largest center performing 6. I'm not sure, it's either Pittsburgh or Mayo Clinic, depending on how you count our cases during that time period. We either had 5 or 6 cases. Overall, there was 77% 5-year survival, which was remarkably similar to that which we see for liver transplantation for hepatocellular carcinoma, and it's better than the survival that we see for patients that we transplant with hilar cholangiocarcinoma and neuroendocrine cancer. There were 15 deaths, 9 of which were due to recurrent disease, 7 retransplants, 1 which was done for recurrent disease, but the U.S. data did not permit prognostic variable determination. With the European registry, there's 149 patients that underwent transplantation at 52 different centers between 1984 and 2014. It's a longer period of time. 40 patients, or almost 30%, had extrahepatic disease, which were usually pulmonary metastases, but also lymph node involvement, direct extension to the diaphragm, and a multitude of other sites. 1, 5, and 10-year survival was 89%, 80%, and 74%. They identified 3 prognostic variables, including macrovascular invasion. Microvascular invasion had already been recognized as a prognostic variable, but when you have macrovascular invasion, you can see it before you do the transplant based on imaging. Waiting time greater than or less than 120 days portended a less favorable outcome. And that's, of course, something that we can vary, because we can just wait longer and allow those patients with very aggressive disease that we know aren't going to do well with transplantation to not undergo transplantation. And they also found that those patients with higher lymph node metastases had decreased survival, and they developed a score associated with survival. These are their graphs, which I think had been shown earlier, showing the difference on the left between those with and without macrovascular invasion. Those with and without a waiting time of 120 days, the shorter waiting time did worse. Patients with and without lymph node metastases. And then this curve on the right showing those that did and did not have extrahepatic disease. And even though the p-value is 0.25, there is a tendency that it's kind of a dangerous thing to say, but it does show that you might expect the patients with extrahepatic disease may not do as well, and that number would become, the difference would become significant if we had a larger number of patients that were studied in the series. And that's why I have some question about whether or not we should categorically include or exclude patients with extrahepatic disease. They developed a score called the HEHE liver transplant score, which goes from 0 to 10, giving patients a 5 if they have macrovascular invasion, a 3 if they underwent transplantation within 120 days, which of course is something we can vary, and then whether a 2 if they had lymph node metastases. But you can see within these two groups that clearly you can stratify the different patients based on the score that they've developed. Um, I'm going to editorialize a little bit, if that would be okay. I want to talk a little bit about how transplant surgeons and transplant programs look at things and how they behave. We've always recognized that disease minimization leads to maximum survival. There are several diseases where excuse me, there are several diseases, for instance, metastatic neuroendocrine cancer, where we know that patients that have less liver involvement than more liver involvement will do better. But as you know, as you keep going down, the patients that don't have any liver involvement at all do the best of all, but they didn't even need the operation in the first place. But nevertheless, transplant programs tend to select patients with an aim to achieve the best possible survival, and our performance metrics are centered on that metric. Patients with less extensive EHE we know will fare better than those with more extensive EHE, and transplant centers will tend to select the patients with less extensive disease to proceed with transplantation. The problem is we're here to help patients, and that is the benefit. And the benefit of transplantation is not survival, but it's the difference between survival with and without transplantation. And survival without transplantation, unfortunately, is oftentimes not known. And the patients most likely to survive are not necessarily those that are not necessarily those that would most likely benefit from transplantation. I'm going to make up some data. Let's say that we undergo a transplantation with a 5-year survival for a group of patients that's at 70%, and then carefully study those patients and develop some prognostic factors and split them into a group that has a good prognosis shown in green and a bad prognosis shown in red. And I chose 55% survival because that's greater than 50% survival at 5 years, which is kind of the reasonable chance for success. Now let's take a look at that top group. And let's say that if that top group did not have transplantation, that their 5-year survival without it would have been 55%, which is only a 30% benefit at 5 years, and it would be the area between these two curves, which would be the total benefit in life years. Now let's hypothetically take a look at the poor prognosis group, and let's assume that without transplantation, they even had a worse prognosis with 10% 5-year survival. Well, the difference here is 45%, and the area between these two curves is much greater for the patients with a bad prognosis than it is for the patients with a good prognosis. This is a situation where the patients that have the worst prognosis have the best benefit with transplantation. But we don't know where that is with EHE because it's very hard to define that yellow line. In summary, we prefer resection for resectable disease, transplantation for unresectable disease, provided and particularly if there's more than 10 lesions, the largest lesion is greater than 10 centimeters, or there's diffuse disease involving more than 4 segments. The prognostic factors associated with survival do drive patient selection. Less extensive disease within the liver, the absence of macrovascular invasion and lymph node metastasis, and observation for at least 120 days to avoid aggressive disease will all lead to better results. Nevertheless, they may not identify those patients that are most likely to benefit. I want to make a couple of comments about organ allocation because I'm sure that many of you are not familiar with it. In the United States, the government directed the transplant community to transplant the sickest patients first. And by that, they meant those most likely to die within the next several months. And we had developed a score at Mayo Clinic based on laboratory values that predicts the likelihood of somebody dying from cirrhosis in the upcoming 3 months. And that's called the Model for End-Stage Liver Disease, or MELD score. That doesn't apply to patients with EHE. And so patients with EHE, like patients with other tumors and that sort of thing, have exception scores that are standardized to the median MELD score at transplantation in the particular area that we are, -3. And it's actually a fairly fair score assignment because we transplant a lot of patients with liver cell cancers, cholangiocarcinoma, and metastatic neuroendocrine cancers. And EHE has been approved for a MELD exception score, but it does require a biopsy to exclude angiosarcoma. So the prioritization system in the United States has recognized EHE as an indication for transplantation. And more recently, local regional boundaries have been switched to distances between the donor hospitals and the transplant centers, which has allowed greater distribution of organs. Now, with our hepatocellular carcinoma patients, the majority of these patients have MELD exception scores, but they are required to wait 6 months before getting a score. That is not true for the other exceptions, including for EHE, and the liver cell cancer patients make up the vast majority of our exception scores. So this system, this change that went into place during the last year, does favor all the other exception scores, including EHE, over the hepatocellular carcinoma patients, which is probably fairly reasonable since we can ablate most of those tumors prior to transplantation. So that's the one, really good news that I have for this group and for our patients with EHE. Thank you again. I'll look forward to our discussion and happy to try and answer any questions that you might have. And I'll join the chat afterwards as well.
All right, we've got a few questions that have come in from the audience here. First question, do you know why some EHE lesions in the liver do not show on imaging? And then the comment, several surgeons have reported finding many more lesions than imaging revealed.
That's absolutely true, but I don't know the answer for that. It's not just true for EHE; it's often true for other tumors as well.
If you saw that a nodule is an obvious merge of two smaller tumors, do you count it as one or two? And I think, specifically with respect to your scoring system.
I'll tend to count it as 2, but when we're selecting patients for transplantation, EHE of course is fairly rare, so we have very, very few cases. But our hepatologists are always trying to advocate for their patients, and that becomes a pretty controversial issue when we're talking about hepatocellular carcinoma because the number of lesions determines whether or not they fall within or outside of criteria. With EHE, it's not that critical for the MELD exception score at all, and in general, there's other reasons to decide between resection and transplantation for patients that have multiple lesions.
Got a question here. What is the longest known follow-up of patients who received transplant for EHE? either in research that you've seen in your practice or elsewhere, to your knowledge?
I know of patients that have been alive for 20 years, but I don't know the longest.
20 years is a very good number. So good to
Yeah.
hear that that's.
Incidentally, our 20-year survival is 50% overall for all of our patients that undergo transplantation, which is actually fairly high compared to most transplant centers, but so it's not unreasonable.
In your experience, in terms of how the system is scoring patients for the wait list for transplant, how are you seeing EHE patients fare in that scoring system? In other words, are they generally getting organs, or are they generally getting displaced by other priorities?
Well, as I mentioned with my last slide, the EHE patients during this past year have, or actually it was about a year and a half, 2 years ago, that they changed the score for the hepatocellular carcinoma patients and have them wait 6 months to have those patients that have terrible disease kind of fall out. But so the EHE patients have benefited from that, but I think we've only had one patient since that change took place, so it's kind of hard to talk from experience. And we're one of the busiest centers for transplantation for EHE in the country. But in general, I would expect that an EHE patient, regardless of their blood type, would have an excellent opportunity to receive a deceased donor organ in most parts of the United States right now. Um, we can always consider living donation, but with that, we have to leave the vena cava in place, and that can be difficult in an EHE patient because it might be involved with the tumor.
You mentioned near the end of your presentation the editorial comment about the prognosis and may not, the benefit to transplant based on the prognosis may not exactly match the medical system's desire for good statistics on transplantations. How are you at Mayo, or how are you aware of doctors otherwise guarding against that possibly mixed set of incentives?
There's no question that there's some conflict there, and we all have to balance that. In order to remain in business, we have to have the satisfactory survival outcome, which really doesn't take into account benefit. If you were to look on that website that I gave you, you would see that you can look at survival at any program in the country. Then they calculate our expected survival based on several well-recognized risk factors, which by and large don't include tumors. And if we don't achieve satisfactory survival, we can't go ahead with patients that have a poor prognosis, even if it's in their benefit. So in general, we try and keep our program's performance at the top of the at top notch, and then we can do what's appropriate for each individual patient. But every program struggles with that.
Yeah. We've got time for one more quick question here, and one quick question popped up. Are you familiar with the transplant protocols in Canada? We do have an international audience here.
Yes. Their allocation system's a little bit different than ours, but quite similar and based on the MELD score, and the programs are run very, very similar to ours. And actually, we oftentimes are involved in each other's discussions, and there's a lot of cross-training that's taken place between the U.S. and Canada and Europe as well.
Oh, good to hear. And we are out of time for the Q&A session. Thank you so much for your time today. And I was not able to get to all the questions, so if you do have a chance to get to the chat in the main website, that would be great. Thank you so much, and we'll look forward to hearing from you in the future.
Thank you.
All right. Well, thank you, Dr. Rosen, so much. One of your slides that really jumped out to me said, you're trying to add years to life and life to years. And I just love that. That's definitely something I'm going to continue to keep in mind. So amazing summary of liver resection and transplant as a treatment option for EHE. And just sincerest thank you for being here today with us.